And a warm welcome back to Woundcasters by Wound Care Today. Today, I have another fascinating guest on the show with me, Arthur Evensen. And I am just so excited to be talking to him. And I hope you will get a lot of value out of this conversation. I certainly am looking forward to a lot of big nuggets that we'll be talking about. So, Arthur, thank you for joining us today on Woundcasters. Thank you for being here. Thank you for doing this. This is absolutely amazing to have you on the show. So, why don't you tell us all a little bit about yourself, who you are, what you do, and how you got to be here today?
Sure. Yeah. Thanks. Well, I just want to start off and just thank you for the opportunity to be here. I'm really excited to talk about some of the research that we've been doing and the outcomes that we're seeing. I am a fresh graduate out of residency. I just spent the last 3 years at the Tucson VA. It's a big, limb salvage reconstruction program in podiatry. And for any of you that are familiar with like foot and ankle research, Dr. Armstrong had a kind of a big involvement in that program. And, so we do some incredible work down there. Now, since I've graduated, I have actually accepted a position out in Missouri in a little town called Clinton. It's got about 10,000 people in it. And so now I'm kind of, playing the rural health game in medicine, it's been fantastic. It's keeping me on my toes. You see, you have to be prepared for anything that walks in the door. But a lot of the same stuff that we were doing at the VA, I'm carrying through into my practice out here with a pretty heavy wound care component to it. So that's kind of my backstory. I started off, podiatry school at Midwestern down in Phoenix and residency at Tucson VA, and now I'm in Missouri.
Yeah, I know we connect a little bit about Missouri because I used to be in St. Louis with the Air Force, so
That's
it's
right. Yeah.
kind of fun to reconnect with people from Missouri. It still boggles my mind to think that my daughter was born in Missouri, right? My youngest daughter was
Sure.
born
Yeah.
in St. Louis. It's one of those things. So I do have to ask. So we had Alton Johnson on the show a little while back, who's also a podiatrist. I don't know if you know
Oh,
Alton
sure.
or not, but he's
Yeah. Yeah.
a big name in wound care, big podiatrist as well. And one of the interesting things that came out of that conversation was the different trajectories that podiatrists take and that traditional medical doctors take, like myself, in that for us, wound care is an afterthought. It's not something that is really part of our mainstream education, but it seems like for podiatrists, it's a different story. Wound care is a big part of your education. You even have fellowship programs in wound care, which we
That's
don't
right.
really have yet in the in the rest of the world. So I do have to ask, where did your interest in wounds begin? How did that come about?
Sure. Yeah. So, I went into podiatry for a lot of different reasons. And I had delved into a number of different pre-med experiences. And, it was kind of, oftentimes when you ask a podiatrist, how do they get into it? Right. It's often that we just stumble into it. And that's kind of the story for me. The love for feet happened later on, but, so once I'd gone into podiatry school, where we take our classes alongside the DOs, and so you have your first 2 years of didactics that are very similar to what I would presume allopathic doctors do as well. But then we start to specialize in our third and fourth year, and really emphasize in on kind of, I would say, maybe four tenets in podiatry. So there's some of us that will go into the wound care heavy side of it. Some of us that choose to go into sports medicine. Some of us that will choose to go into trauma. And then the other group falls into kind of the bread and butter podiatry, bunions, hammer toes, and such. We're all trained across the board, but we all kind of find that niche that just really speaks to us and that we love. And so in our fourth year of medical school, just like the allopathic and the osteopathic docs do, we go on rotations around the country. Because there's less podiatry, we actually travel a healthy amount. I was in throughout 26 different states when I was in my third and fourth year, and took my wife and kids with me. And so we got a chance to really see a lot of variety in terms of how podiatry is practiced and the different ways that you can emphasize in it. And so along that journey, I really saw a lot of wound care. But I wouldn't say that I really had my passion for wound care until I got into residency. I chose to go to the VA because my father-in-law passed away at the Salt Lake City VA while I was there as a student, as a medical student rotating. And that left kind of a lasting impression on me that I was like, well, I want to at least spend 3 years of my life giving back to the VA because they had treated him so well. So I chose to go to the Tucson VA strictly for that. And so once I got down there, I was fully immersed in the wound care world. And at my particular residency, what they do is they have you do on-call work for 3 months straight. And that's in your first year. And they really break you in. And during my first 3 months of call there, I ended up picking up a patient that I started doing, taking care of this wound. It wasn't going anywhere. The outlook wasn't positive. He had declined to have amputation. This was a Vietnam vet. He was a ranger. There's a personality type there, and he said, he got out of Vietnam with both feet, and he's going to lead this world with both feet. And he had a couple things that he had to do in his life that were all going to be wrapped up by December that year, and so that was his goal, is just to survive till December. So I saw this guy every week, and oftentimes every day, because I was doing just nerve blocks to help him through the pain. And we were able to keep that limb functional and worthwhile until he met December, and he was able to take care of his things. And he went home peacefully, passed away. He was able to have a spaghetti. That was a big thing he wanted, was spaghetti and some cigars. And anyway, it was at that point, so I'm 3 months into residency, and I realized that every action I do with a wound means minutes on a person's life. And he was a prime example of that. Every single time I saw him and I scrubbed that leg and I put a new dressing on and I did, the wound care there, I was buying him just a little bit more time to get through to that goal. And that experience just really changed me fundamentally. And I became fully invested in wound care. From that point on, I went above and beyond really in residency to make myself a wound care person. So I did a lot of research, which we'll talk about here and such, but it was a lot of effort on my part outside of the normal residency stuff, but it just became who I am. And so that experience was really what kind of turned the tide for me.
That's truly a fascinating story, and it brings me back to another piece of the conversation that I had with Alton. In that wounds are a big part of podiatry, and all the problems that you have with feet, right? All the various deformities. One of the complications is going to be a wound. So wound care is a big part of podiatry, but then there are still many pockets in this country where the primary treatment, and this is something that for podiatrists still doesn't make any sense to me, the treatment is amputation, like you mentioned, right? You offer that as an option. But by amputating the foot, you take away the one piece on the body that you know the most about, that you're supposed to work on, right? So you take away your own business by doing an amputation. So I'm wondering why you think that is, because it's one of those things that I know the Save a Life Foundation is doing a big part of, is trying to reduce the amount of amputations we have in this country. But I'm wondering from your perspective, why we are still doing so many amputations in this country. I mean, I could share my own stories about foot wounds that didn't require amputations that ultimately ended up with an amputation. But I think in the hands of a good podiatrist, foot wounds do not require amputations, at least not major amputations. I mean, they may require bone resections here and there for osteo, but they certainly shouldn't require major foot amputations. So I guess my question is, why do you think that is? Why are we still so hung up on doing amputations when we have technology to heal wounds, or at least prevent them from getting worse?
Yeah, so I am a big advocate for limb salvage, and that was something that I really discovered in residency, especially with my vets, because again, they have a mindset of I'm going to push through and fight this, and they're not one. These are not men to give in. So, when it comes to podiatry in particular, I think that we've been shown. I don't quote me on this, but there's somewhere out there that if patients that are under podiatric care are 80% less likely to go on to amputation, and it's something that we really pride ourselves in. I think that probably across the board, even amongst podiatry, the argument for amputation versus limb salvage is really twofold. One is, the burden to the patient, right? So limb salvage is going to require frequent visits. It's going to require wound care. Sometimes it can be painful to have that wound care and such. So that takes a burden out of the patient as opposed to amputation, where perhaps their healing is quicker, right? And they can get on with their life. But as we know from Dr. Armstrong's work and others, that once you have an amputation, your 5-year mortality rate is anywhere between 50 to 77% within the next
Right.
5 years.
Right.
So while you can maybe solve the issue immediately, the cost to life is monumental to begin the amputation process. So I think that's the first aspect, right? Is the cost, to life, the quality of life, and things. And that's an argument that I hear on both sides of the aisle. And I do think that's just kind of a patient dependent situation. The other side of it is cost. And I think in healthcare, we know that cost is always a factor, unfortunately. So, on one side, an amputation can be very cost effective. Generally, once it's done, you pay for the OR, you pay for a couple weeks of follow-up care, but the cost to the system is maybe immediately, at least in the near future, much less than, say, limb salvage, where we're going to be doing grafts and we're going to be going in there and using advanced wound care modalities, topical oxygen, negative pressure therapy, lymphedema pumps, you name it. We've got a lot of things that we throw at it. And again, don't quote me. But I have the sources there. The research is out there that shows that the long-term cost, though, of salvaging a limb and preventing those hospitalizations and the death and the things that happen years down the road from amputation, it ends up being that it's just a higher upfront cost for limb salvage, but may perhaps equal to or less than the cost overall, right? And so that's why I'm a big proponent of it, is that I think I can make the argument in most patients' cases that, one, limb salvage is going to preserve their life expectancy and it's going to preserve their mobility and their dignity. And two, that the cost is going to be cost benefit ratio makes sense. That while it may cost a little bit to throw a graft on there up front, the long-term down the road cost of amputations and then below knee amputations and rehabs and prosthetics and all the things that happen, it ends up washing out in the end. So I think that's a big mindset in the industry across the board, whether it's podiatry, ortho, vascular, gen surge, across the board. I think it's the amputation's been kind of the go-to, and now they're starting to see that we have the technology to salvage these limbs and preserve, like I said, the life expectancy, their dignity, and their ability to be mobile. So
Yeah. No, I wholeheartedly agree with limb salvage. Like I said, I have my own share of patients that I can think of where I was treating foot ulcers, and then they ended up in the hospital for maybe some other reason, even, and they ended up with an amputation when I was really trying hard to salvage a limb. Right? It's can be frustrating to deal with that as well. But you mentioned grafts, of course, and I know that's been a heavy part of your research. So let's talk a little bit about that a little bit. What is your area of interest, and what have you researched?
Sure. Yeah. So while I was at the VA, and I think what is that statistic out there? Like 60% of doctors do at least some of their training at the VA. Something along those lines. Yeah. Most doctors out there have spent at least a little time at the VA, and so I think it's kind of universally understood that at the VA, money doesn't always exist, and that is what's really cool. You can go to the VA and you can practice medicine based on the merit of the treatments that you're doing and what makes sense for the patient. And there's money everywhere, but for the most part, this is probably the one area in the world right now where you can just go and practice medicine based on what makes sense. So when I was there, we had patients coming in that we were doing amniotic allografting with, and we had a flowable version and a hydromembrane that we were using, and we saw incredible success using those amnio membranes, and especially because we weren't necessarily inhibited by reimbursements, we were able to apply them on a more regular basis and utilize them in wounds that you might not typically get to see in private practice and whatnot. So that was kind of what got me into it. I ended up, I had a group of patients, I call them the Fab Four. They were these guys that I just developed a really strong relationship with. They didn't want to have amputations. They wanted to salvage their limbs, but we had tried the amnio graftings on them, and we weren't seeing the success. These were chronic wounds. These were very, very sick patients. I mean, one of them had lung cancer and AIDS. The other one's like in their 90s with peripheral vascular disease. I mean, these are patients that were not going to heal, you know, and so what we ended up doing is we tried the kitchen sink method. It's one of what one of my attendings said. We throw everything at that wound except for the kitchen sink. And so I trialed putting on the amniotic allografts with this really cool product called Anthem. It's marketed in the private world as Phoenix with Renovoderm, but essentially it's an electrospun synthetic extracellular matrix dressing. And what's cool about it is that as it breaks down in the wound, it ends up raising the pH of the wound and offering the scaffold that allows for those proliferative cells to kind of go in and heal the wound. So we ended up doing a combo with it. And that's, I think, that's where I come in with this whole money and VA aspect, is that you probably couldn't get that authorized out in private practice to use two of these really cool products together. But what we found is that when we started pairing these chronic wounds that were not healing, these patients that were just not on paper should never have healed, ended up healing. And we ended up taking those chronic wounds in my Fab Four patients from chronic to healed within about 6 weeks. And we published that paper when I think I was in my second year of residency. And that really got the ball rolling, because once we had discovered this really cool synergistic effect of the combination therapy, we were able to start applying it with a lot of the other vets. And so, so I had that initial kind of, I would almost call it a pilot study. And then over the course of my second and third year, I ended up getting IRB approval for a retrospective where we included we had 21 patients, and we compared and contrasted monotherapy with just just with the amniografts, monotherapy with just the synthetic ECM, and then combination therapy. And we were able to demonstrate that there is a significant difference in the healing potential when you use those two in combination. And so those two papers really is what got me, I guess, my foot in the door. And yeah, and it helped
Pun
me.
intended, right?
Exactly. And from that point on, I was able to kind of engage with the global wound care community, because we had found something that was unique, and we were seeing incredible results there at the VA. So that's kind of my relationship with grafts. But
Yeah, no, this is interesting. And actually, that was one of my questions to you, is if you had any data on because any data on the use of either of those two products individually versus combined, because this is one of the problems I have with a lot of research that is being done in the wound care space. You throw so many different variables into the mix that it really then becomes a question of, did the product that you're trying to research here actually do what you said, or was it one of the other three things that was happening at the same time, right?
Yeah.
So trying to break that apart is sometimes really difficult, because these patients are complex and they have chronic wounds, and we are trying to do multiple different things. and
Absolutely.
even a
Yeah.
secondary dressing you put on the wound, right, will have some effect on the wound. And so then the question becomes, well, was it the secondary dressing? How many different secondary dressings did you study, right?
Sure.
Makes research in wound care really challenging to do that. So that's fascinating. So it's a synthetic extracellular matrix and an amniotic. I'm wondering which one goes in contact with the wound bed first, and
Sure.
does that matter,
Yeah.
right? Does the amnio go first and then the ECM, or does the ECM go
Yeah.
first and then the amnio? Does it
So
matter?
yeah.
What have you learned?
Yeah, so for me, what we ended up doing was kind of developing a protocol that we could standardize across the board. Um, if you talk to any big wound care provider out there, they'll say the wound bed preparation is 90% of the battle, right? So
Yeah, right,
with
right.
all of these patients, I would take the betadine scrub brush. We scrubbed all the way from knee below, rinsed off with sterile saline. Then we used ChloraPrep to clean the whole foot. We did our debridements and cleaning of the wound measurements. And then we would graft over the amnion to the wound bed itself onto the granular tissue. And then over top of that, we would hydrate the ECM and put that over and then protect it with a non-adherent. And we kept those patients in a dry, sterile dressing over top for a week at a time. So they didn't change it. There was no exposure. They would come see me every week and we would take down that dressing. So that was kind of our protocol with that. The rationale behind that was that synthetic ECM not only serves as, again, a modulator of the pH in the wound, but also as the scaffold for those mesenchymal stem cells and the other growth factors to then grow into. And additionally, what's kind of neat about at least Anthem or like I said, Phoenix in the private world is that it serves as a barrier to the wound. So once you got it wet, it would kind of dry and make like this. It just kind of made for a micro wound environment that was protected from the outside. And so the amnio would sit there on the granular tissue. You've got this hard kind of shell from the Anthem. And it was just kind of a recipe for success. So that was kind of our rationale for layering it the way that we did. But,
Yeah, that makes sense. Now you mentioned pH, and I have to talk about pH here for a little bit, because for one, I'm a chemist by background before I went to medical
sure.
school, and two, we had discussed pH and wound healing with Ira Herman in our very first episode on this podcast. So I do want
Cool.
to come back to the pH and that. So you had mentioned that it raises the pH, but one of the things that we have found, right, is that high pH, alkaline pH, can actually impede wound healing. And that's the whole idea behind products like hypochlorous acid, to drive the pH back down to a more physiologic level. Although within the tissues themselves, right, on the skin, we have a pH of about 5.5, but within the
Sure.
tissues themselves, that pH actually is somewhat higher. So what was your experience with all these products and the pH,
Yeah.
since you mentioned it?
So I misspoke. It lowers the pH, and so it makes the wound more acidic. Um,
Okay.
so yeah, and so by taking the acidity of the wound and making it more acidic, it creates this favorable microenvironment that one helps us with our growth factors and the production of collagen, and as you know, the other cell mitigators that come into the wound, but also it helps those bacterial end products become less toxic. We know that as the pH increases and becomes more alkaline, that the bacterial byproducts can become more toxic and potent. And that brings me to an important point with the other reason that we think that the Anthem and the amnio work so well together. The as you may have experienced in the past, when you put on a graft, a lot of times what happens is if that wound has infection or it's super alkaline and it's just not a favorable wound, we can see actually rapid cell clearance from those grafts. They end up just failing. They don't
Right.
work
Right.
and it goes away, right? So by pairing it with something that modulates the pH, not raises, but lowers it to a more acidic range, it makes it more favorable for those mesenchymal stem cells and for those growth factors to activate and work. And so we found that was, or at least that's what we hypothesize is one of the reasons that combo is so synergistic, is that it's taking those very fragile grafts and allowing them the most optimal wound environment for them to apply. And additionally, I think that's maybe another thing that you may hear from other folks out there. It was certainly something that I had to overcome, even amongst my peers. There was this notion that we don't want to put amnio on an infected wound, right? And I think there's an argument to have a grossly infected versus a chronically infected wound, right? But the reality of it is that if you're applying those growth factors and those things that the body needs in order to heal that wound, and you're putting in Anthem there to modulate the pH, you can put it into these infected wounds, and it will help the body to better respond to the infection and to heal the wound. That's, at least again, from my experience, what I've seen. And so I think that was also a really kind of a neat aspect, was to be able to say, oh, okay, the fact that the wound has some infection there, or maybe there's some subacute osteo that's cooking underneath there, it's okay to apply these grafts as long as we're pairing it with something like Anthem or Phoenix. So that was kind of our experience with that. But.
I think it makes sense to put these, really expensive products in a potentially chronically infected field. I mean, with an acute infection, you have higher exudates, and it becomes just really expensive slough most of the time.
Yeah.
But most of these wounds that exist for weeks and months and years are chronically infected, right? And
right.
Really, the reason the body doesn't close them. I mean, for me, a wound that doesn't heal doesn't make sense, because our skin is our first line of defense against the outside world. We want our skin to be intact, right? I mean, it's like you've been at the VA, right? It's like having an outpost somewhere in Afghanistan, but we're going to leave the sentries not at the gate.
Sure.
Makes no sense, right? Just leave the gate wide open. Just leave the gate wide open. Makes no sense, right? We want that defense, that first line of defense against the outside world. So I think from what you're describing between the amnio and the ECM, what it really is doing is providing the chemistry, the biochemistry in the wound that the body is not able to provide on its own. And so even if you have a somewhat chronically infected wound, your body is still trying to heal that, or wants to heal that, or wants to close that in some way, shape, or form. And so because it's not able to do that, you're just simply providing the mechanism to help out in ways that your body's not able to provide on its own. So I think that makes sense to me, that even in chronically infected wounds, you can use these products. But what I'm more interested about is, you went from the VA, where you have resources available to you to do these kinds of expensive treatments that are seemingly very successful, now to rural Missouri, where I'm sure your resources are not quite as robust. So how are you dealing with that now in the rural Missouri area with being able to heal wounds?
Yeah. So that is something that I'm learning as I go, and it's there's certain aspects in rural health that actually do kind of facilitate the access to some of these things. So, for instance, my hospital that I work as a critical access hospital, and so it receives federal funding. And so when I first initially took this position out here, I was a little concerned that I wouldn't have access at all to these things. But I have been able to get approval for a lot of these different things. What I haven't been able to get approval is for combination therapy, using one and the other, right? And so I think that's probably something that I'm trying to advocate for out here, at least locally, with the Missouri Podiatric Medical Association, and then being an advocate at a federal level for approval and access to these types of products, but also trying to take at least some of the principles that I learned from that and apply it in kind of cowboy medicine, right? So we learned that if we were able to create a microenvironment that was favorable to the graft, that we could see better success with the grafting. So I've implemented that same washing, scrubbing protocol that I mentioned earlier. I'm doing the week-long dressings where they don't access the wounds at all during that week. And we're trying to implement as much of that as I can. But yeah, it's a challenge. It really is a challenge, because I'm coming from this wave of success where we were taking wounds and healing people at record numbers at that VA. And I'm coming out here and I'm seeing the exact same wound, the exact same patient. And I'm like, I don't have that to give to you, and that's frustrating as a provider, and to know that the technology exists out there, but we don't always have access to it. So I guess to answer your point, I'm trying to utilize what I learned and use my resources to the fullest extent, but I'm also really emphasizing and focusing my time on advocate to try and make some changes policy level to get access to these out to critical access hospitals and hopefully private practice eventually.
Really, I mean, that sounds like a treatment that really is required anywhere. What
Yeah.
I'm wondering is, being in rural Missouri, your population is probably not financially all that resourceful, but you've been out of residency now for a short amount of time. So I don't know if you've come across a scenario where maybe a patient is private pay, self pay for the amniotic, which you can buy online pretty easily.
Right.
And you just get the third party payers to cover the ECM. I don't know if
Yep.
You've come across that scenario. Is that something you've considered?
I haven't come across that scenario yet, but that brings me to an important point, and it was a lesson I learned from my wife. Actually, she was at a dental conference something like 8 years ago, and one of the speakers was talking about his daughter who had cancer, and they had a doctor there that essentially had made the decision for them that they couldn't afford the treatment. And so he didn't present that option to the patient. Right. And so the point of the presenter was that we shouldn't make decisions on treatment based on a patient's ability to pay, that they need to have the option to know that this exists and that they can, that it's in there, that the treatment exists, I think is really kind of the point. And so,
Right.
While I've been out here, what I do is I have print offs of my papers that I give the patients, and I say, look, this is what we have. There's this combination therapy that I've used. Later on in the show, we'll talk about the antibiotic loaded cement that I've been using, and I'll say, hey, these are the things out here. This is what I'm going to try and do here. And we can try and work at what we can, but I try and just arm them with the knowledge that these things exist in the hopes that they can find it. And so while I haven't had anyone come and pay for an amnio on their own, what I have had is veteran patients that have come here on a community care consult that I've then sent back to their VAs and said, hey, these are in the VAs, they're on the federal supply schedule. Go and talk to them, take my publication and talk to those podiatrists there and see if this is something they can do. And so I'm just trying to arm the patients with the knowledge that they don't have to live with this, that the stuff does exist. So,
yeah, that's an important point. I mean, that's something that I know Herman and I have talked about, and I know Brock Leiden and I have talked about this offline. He'll be on the show and hopefully in the next few months as well. Is that patient education piece where patients really, I mean, they don't know what we know. And trying to let them in on our secrets and what we know so that they can make better and more informed decisions about their own care is good medicine. I mean, that's just what it is. It's good medicine, right? It's a partnership. I'm not here to tell you what I want to do. I'm here to help you figure out on your journey of healing what's the best option for you is, right? So that's an important piece. But you mentioned the antibiotic cement, so I do want to hear more about that.
Yeah. So, we had this really incredible wave of success with the combination therapy. But we would still get those wounds that were acutely infected, to where, it was just, there's no amount of pH modulation you can do. If it's pussing out and there's a bunch of osteo, you got to do something about it. Right. The problem is that when you come across a lot of these wounds, most of these guys had some aspect of arterial or vascular disease. And in a number of my patients, which I've done some publications on, they were vasculopath patients that had these ulcerations that were infected and were just not responding. So the question then becomes for the clinician, how do I get antibiotics down to a source if I can't get blood flow down there.
Right.
You can take a pill, you can do an IV, but if the elixir of life is not coming to the wound, that antibiotic is also not getting to the wound. So in the past, what they've used is like PMMA beads, polymethyl methacrylate. I
Hmm.
remember in residency got pimped on that, right? So, and it's a fantastic product. You mix it up, it creates a hard cement, and that you load it with antibiotics that it then elutes over a period of time. The problem with PMMA is that one, it's exothermic, so sometimes it can cause issues with heat. Two, it has a couple toxic byproducts that happen as it goes through the elution product, and people respond to that differently. And three, probably, well, three and four, three being that it can serve as a nidus for infection because it is a cement. So just because it holds antibiotic, it can also hold bacteria. But
Right.
the
Sure.
biggest issue is that it requires a second surgery. So you can get it in there, you put beads on a string or whatever into the wound, but then you have to go back in and open it, and now you're back with another wound, right? So
Yeah.
there's this incredible new line of antibiotic-loaded cement that's kind of made into the market, and the company that I have used, and I think we're kind of the forefront of that, was Biocomposites. The product is called Stimulant. Stimulant's made out of medical grade gypsum, which is what our drywall is made out of. And what's fascinating about it is that it resorbs in the body. So instead of having to remove it later on, instead of serving as a nidus for infection, this is something that will slowly dissolve over a period of time, in my experience, about 30 days. And as it goes through that process, it'll elute the antibiotics into the local
Mm.
area. So what we started doing was using that as they had indicated for deep penetrating puncture wounds, things like that. You'd stick it in, it would drain, and all that. It's really only indicated as a void filler right now that for FDA approval, basically essentially like PMMA. Well, okay, long story short, I had this gentleman come in. He's vasculopath. He has a transmetatarsal amputation. It's completely dehisced. He fell through follow-up. This was done out in the community. He's coming to the VA. I can see his metatarsals hanging through the flap. And he's got staples everywhere and gunk and pus. And it's a below knee amputation, right? Now you see that clinically and you're like, okay, it's time to go. Well, this guy is the primary caregiver for his wife, who absolutely needs him. She's on dialysis, and there's no one around. They live in the middle of nowhere. So having a below knee amputation is a death sentence, really, for him and his wife. I mean, it's pretty life changing. So anything that we could do to try and salvage that limb and allow him to continue giving care to his wife. So what we ended up doing is we cleaned out the wound and we put some retention sutures in. And then, as to my knowledge, the first time ever, we used the antibiotic cement as a topical. And so we
Oh, interesting.
sprinkled it. Yeah, we broke it into little tiny micro pellets. It comes with like a mold, but we use smaller ones, and we sprinkled it across the open flaps, and we left them open to close by secondary intention there. And so we were able to over the course. It took us about, I think it was like 8 to 12 weeks, somewhere in that realm, but we were actually able to completely arrest the infection, control it, and then slowly each week the retention sutures got tighter and tighter, and we closed that TMA and healed that patient up. And it was just this really amazing case where like that foot should have gone. They had no blood flow and it was grossly infected. And those antibiotic cement beads were able to control that infection. And of note, that was also another case where we used our combination therapy. And we used that anthem in there to help modulate the pH, and we had the growth factor. So it was kind of this trifecta of these three wound care modalities that we used in one patient. And that got the ball rolling into a whole slew of other patients. Again, it was kind of just, it caught fire at that VA, and we started using these stimulant beads for infections all across the board. And we saw incredible results. And we can go into it later, but one of the interesting things that kind of came of that is that we then started experimenting using it in kind of like the masculate technique. I don't know if you're familiar with that, but it's like an old military technique where, someone gets shot in the femur, it shatters the femur. How do you keep the limb to length? You stuck in PMMA in there. It creates a little osteosheath, and then you put in a bone graft and you save that limb. Well, we ended up starting using it that same way, but with resorbable cement to hold metatarsals and raise to length. We would resect the osteo, stick it in. It would create an induced membrane with an a periosteal sheath. And then each week we would take it out, make a smaller pellet of the cement, keep adding the amnio and the anthem. It would fill in with scar tissue, and we were able to have these patients that wouldn't have contractures. There were no gaps. They could keep their big toe, and they
Wow,
had a
that's
functional
fascinating.
unit. So
Yeah,
yeah, that was kind of the last major research project I did before I left. Was this masculate technique using the stimulant. So and that has been something I've been successful at getting out here. We were able to get it covered, and so I'm using stimulant at least 2 or 3 times a week out here in this rural community, and it's
that's
making a
awesome.
big difference. So
That's
yeah, so that's a
fantastic.
lot. I know I kind of a little word vomit there, but it's a very exciting. It's cool stuff.
No, that absolutely is really cool stuff, and I think your point is well taken. That if you have no blood flow, how are the antibiotics going to get there? I mean, that's one of the questions that I've always asked. Why are we putting you on long term, whether it's oral or IV, right? If there's no blood flow, the antibiotics ain't going to get there. So all we're
No,
doing
yeah,
is creating side effects with the antibiotics. So having a local delivery system is definitely very very useful, and I can see it to be used in not just foot wounds but other types of wounds as well, for the same
absolutely.
reason that I think there's a lot of what we call pressure ulcers, may not all be related to pressures. They also may be a blood flow related issue with
For
vascular
sure.
dermatomes, and so if we have a lack of blood flow to those areas, again, IV and oral antibiotics ain't gonna get there. So
Right.
what do we do? What do we have as a local delivery system to bring antibiotics there? But my question to the antibiotics then is, what's the choice of antibiotics? How do you choose? What can you
Yeah.
deliver with it? Is it because I'm used to orthopedics doing bone cement all with vancomycin powder and not using nothing else. So I'm just wondering what you're
Sure.
using
Yeah.
for your antibiotic
Yeah.
choice here.
So we experimented with a lot. And so initially we started with Vanco because that's the classic. And typically, if I'm doing a batch of beads, I'll use about half a gram of vancomycin in there. And then we pair it with usually some sort of aminoglycoside, so gentamicin, tobramycin, something to kind of give us a nice broad coverage. And that's probably my go-to recipe for my antibiotic beads in general. But then you get those infections that sometimes are, Pseudomonas, right?
Hmm.
And other ones that might be resistant to such. And so we experimented with various different ones. Sometimes we were taking pill capsules and sticking in there, and so and we had great success across the board. So I would say again, to your question, generally speaking, for podiatric type wounds, Vanco and some gentamicin is going to cover most of your critters out there, and it's effective. But we did titrate it and use it if we had sensitivities back, and we could make that. And what's cool about stimulant is that it can be a liquid or a powder. So
Okay.
that was cool. So we would get the little ampules of liquid gentamicin, and we would use that to reconstitute the cement to get it in there. And so if you got ceftriaxone, right? We use that it came in a vial, and we use that to reconstitute the cement on a patient. And so it's just very versatile, and you can just kind of make with it what you want. And it will change too. Like, so if you want something that will resorb very quickly, you can add a little extra moisture to the mix, and it will kind of make it more grainy. And
Mm.
those kind of resorb faster. And then I use that usually for a very acute infection where I want antibiotic in there and I want it fast. But if I've got one that's been a chronic osteo that I'm just trying to keep arrested and quiet and whatnot, I'll put in and I'll mix it so that it's a little firmer and so that those antibiotic beads will last longer. So, so I would say not only does the antibiotic choice change, but also the consistency and the size of the beads and how you put them can be changed and modulated based on the wound, which is really cool.
That is really fascinating, and and I guess my question has to be, do the antibiotics matter? And I'm asking because what you're describing is good outcomes across the board, no matter the choice of the antibiotics. So is the antibiotic really doing anything, or is it the stimulant itself that is providing maybe some antimicrobial effects or some tissue effects that help with immunomodulation to help the body clear the infection on its own?
I
Do you have
think
any data on just using the stimulant by itself?
I have never used it by itself. I think you raise a really interesting question to it. I think there would be some potentially reasons why it could be beneficial. One of which is that as it drains, it creates a constant flow of fluid that's coming out of the wound that might be wicking away some of the other exudates and toxins and things that would be in the wound. Um, so potentially there's some aspect of that. I also, from reading through the research when they got their FDA approval, they were able to demonstrate that it does not act as a nidus for infection.
Hmm.
How that happens and how that is, I don't quite understand. I'd have to really look at the research. But as we know with the PMMA, that can become colonized, but they were able to demonstrate that it cannot, or that it doesn't get colonized. So maybe there is some inherent biochemical property to it. I myself haven't ever used it without antibiotics, but very, very interesting. And I also think, as when we're going into a wound, even if the target organism is cultured out as Proteus mirabilis or whatever, oftentimes you've got a few other concomitant infections that are going in
Sure.
there. And so if you're just throwing vanc in there and nuking the other competitors in there, then the body can focus on maybe the one problem bacteria. So even if your antibiotics aren't perfectly targeted, I think it's that almost sterility of the wound by using them that allows the body to respond to maybe the causative organism. I don't know. All I can say is that I've seen incredible success with it, and I also really think that it may be the future of antibiotics, in the sense that we have all these issues with like resistance. We have all these side effects with, C. diff and,
Right.
and things that happen and whatnot. And I could totally see us getting to the point where we just make and load antibiotics locally into wounds and don't go down that route at all. And it could be a really big thing. So I'm still learning with it. It's kind of an experiment every time, every patient, but it's been really exciting. It's cool
Yeah.
stuff.
So you kind of my next question to you actually was going to be, with all the research you've done, with all the experiences you've had, with all the good outcomes that you have had with some of these procedures that you've been doing with the amnio and the ECM and the stimulant. What are you most excited about going forward into wound care? What's the next big thing that is something that really gets you excited?
Yeah. So from what I experienced at the VA and this concept, it's almost like a philosophy in wound care that we kind of came across, which is combo. How can we take different wound care modalities that often don't speak to one another, totally separate reps, totally separate companies? They all have their own individual research that shows their products. How can we combine them together and create these synergistic reactions? And so I think what really makes me excited about the future and what I'm getting into is the development of products that come as a combo. So instead of me having to authorize an amnio and an ECM and a resorbable cement, can we make a product that has amnio with a synthetic ECM infused into it that's impregnated with antibiotics? Can we make something that's a universal one product that we can then just get authorization for to put into wounds? There's not a silver bullet for all wounds, but I do think that there's a huge market out there if we could get these companies to think and work together and create combos with their products. And I think that might actually help us with reimbursement and getting access to it too. If we can have something that's ambient temperature, that's easy to store, that covers all your bases, has your antibiotics, then when it comes to rural healthcare, all I need is to stock one or two combo products, and I can take care of 75% of the wounds I see. And so that for me is what is most exciting, is being on the advocacy point with these products and saying, hey, we've been doing this for a long time. We all kind of look at this through this little lens, like our product is the best. We have to compete with each other. Why not change the picture to how does my product potentially work with your product? And can we make a partnership? So I think that's what I'm excited most for going forward.
Yeah. No, and I agree with that combo approach. I mean, I've noticed some similar synergies between using collagen with negative pressure or collagen with a copper alginate. And so the idea that it always has to be one dressing or one intervention that does everything is outdated, especially in these complex wounds where there is more than one thing wrong with them. We do need a multimodal approach, right? So I absolutely agree with you on that. Well, I want to be cognizant of our time here. So any final words, any last thoughts, anything we hadn't touched upon that you think the world of wound care needs to hear?
I just think that, in terms of talking about limb salvage and again, I think the biggest kickback that I've gotten with my publications and with me advocating this has always been the cost to life, right? Salvage versus amputation, and the cost of the product with dollar signs. And so I guess what I would love to leave the audience with is that when you're doing wound care, you are preserving somebody's independence, somebody's dignity, somebody's mobility, and you are oftentimes adding minutes, hours, days, weeks to their life. Every single dressing change matters. Every single product you put on there is buying them time. And so I think that, as wound care advocates and limb salvage advocates, I think we have to keep that mindset when we're developing new products, when we're going into research, and when we're out there trying to advocate for the cost to the big federal level, is that these products aren't just there to fix the wound and heal up broken skin. That if I can fix this ulcer now and prevent an amputation, I can save this guy's life. And the memories and the life that he would have had. So that's kind of my takeaway from it. That's something I really try and push with my staff, and I tried to push with the residents when I was the chief resident there. It was really trying to infuse this long-term perspective into wound care and why it's so important.
Yeah. No, that's beautifully said. It kind of reminds me of the mantra. It's not about the hole in the patient; it's about the whole patient. And I think that's very well said. And I think that's a great place to end this conversation with, Arthur. So thank you again for being here today. With all that, thank you all for joining us today on Woundcasters by Wound Care Today. Keep in mind, if there are any particular topics you want to hear about or guests you would like to see on the show, reach out and contact us. If you're listening to this on a podcast app, be sure to subscribe and leave us a 5-star review so others can find this content more easily. And if you like this particular episode, share it with a friend. As always, be sure to tune in next time as we explore yet another vital aspect of the challenging and rewarding field of chronic wound care. Ciao.
Thanks so much.